Welcome, everyone. Happy April. Today, we are talking about reunification and patient tracking, the first 60 minutes, and communication. Next slide, please. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, as part of several cooperative agreements. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For more information, visit hrsa.gov. Next slide, please. There are no relevant financial relationships or disclosures to report today. We will give you information on how to apply for CE should you desire it later on in the presentation. Most of you have seen these announcements before. I want to call your attention to the fact that the focus area web pages are live. There's a suggestion that you update your name to include your hospital name. I'm not sure how many characters that would warrant, but as a workaround, you're welcome to introduce yourself in the chat and add your hospital name there, depending upon what works for you best. Next slide. A big shout out and thank you to everybody that has spent so much time planning this session, especially Anna Lynn and Christy Deutschman, as well as all of our speakers today and our leaders. Thank you so much. Next slide, please. We have a tight agenda. These are all of the things that we hope to speak about today. Tracy, I'll get to you in just 2 seconds. Next slide, please. These are today's objectives. And yes, those birthday cakes are for Christy. Will you turn on your camera, please?
Laura, I can take over. Hi, everybody. This is Sarita Chung. I'm part of the planning team on Peds Emergency Medicine at Boston Children's Hospital. We're so delighted that you're here. We know that you have a very busy schedule, and so we are trying to plan these sessions with you in mind. So any feedback that you would like to provide, please let us know, and we are trying to respond to learners and see what makes the most sense. Prior to these sessions, we sent out a Padlet, and that's with information about resources that we have kind of curated for you to see if they are helpful for you, and also a worksheet for you to work on as a gap analysis. But our objectives, we have 3 objectives, and we actually want to do 2 breakout groups today, so you can see how we're totally ambitious and we're hoping to get through. But we're going to first talk about SMART aims and thinking about SMART aims that you would think about with family reunification and giving you some examples. And then we'll talk about activation of your family reunification plan. And we're so delighted to have 2 amazing speakers from Texas Children's Hospitals who have had to activate their plan many a times. And so to kind of get their insights, and then also talk about communication concerns that you might have related to pediatric patient tracking reunification. And once again, our colleagues from Texas Children's Hospital, Carrie and Chelsea, will be able to kind of share what they've learned and what they've used in practice. Next slide. So this was in your Padlet, but this is some resources for you to have if your institution's interested. The Region FEMA 5 for Kids did a module on family unification, developing 5 modules. They're really short, they're 10 minutes, and really going through kind of the steps that you would need to take to think about your family reunification plan, including legal concerns and recovery. So this is something that you, if you'd like, you can look at. And once again, it's on the Padlet that we shared earlier, I believe yesterday, that you could just click on. Next slide. And once again, this is the Texas Children's Hospital colleagues generously offered their Family Reception Center plan to give you an example of a plan that they have created and thinking about their family reunification planning. And so now I'm going to turn it over to Tracy. Tracy, if you could introduce yourself, and this floor is all yours. Thank you so much.
Thanks so much, Sarita. Hi, everybody. I'm Tracy McCallan. I am a physician at Rainbow Babies and Children's Hospital, working in the pediatric emergency department there. And I'm the Associate Chief Quality Officer for Education at Rainbow. So I am the QI lead for this domain for reunification, and excited to show you guys a little bit about how the SMART aims may apply to what we're working on here in this domain. So just a quick refresher, a SMART aim has this acronym, which stands for specific, measurable, so typically want to have some numeric goal that we're looking at, actionable, so within the control or influence of your team, keeping that scope nice and narrow, relevant or realistic, which are aligned typically with your organization's priorities, and then time bound, so occurring within a certain time frame. Next slide. So looking at our disaster checklist in the domain for reunification, the recommended activities, these are arranged here for you to see also with the measures that were agreed upon for the DRC. So you can see that there are 2 process measures under the patient tracking and family reunification activity. And there is an optional outcome measure that you can look at under space. So we're going to look at this a little bit more in depth with some examples for each of these activities. So for the pediatric patient tracking and family reunification activity, this is an example of a SMART aim you could use at your institution or wherever you might implement this. So with that time-bound piece, in the next 4 months, a child identification form will be completed for 90% of unaccompanied children who present to the ED during simulated or actual disaster response events within 6 hours of presentation. So this would look at, in the next 4 months, any either real or simulated event you have where you would be activating your reunification plan. We would want to aim for 90% of the children during that event having this child identification form utilized. Next slide. Another example looking at the family reunification planning would be that a needs assessment would be completed by 75% of identified local community partners by a specific date. And here we chose about 3 months from now. So just another example of how you could create an aim statement around this domain. For the space use, we utilize this to look at that optional outcome measure of reunification with the guardian by looking at use of the family reunification site. So for unaccompanied children tracked using the hospital reunification process, we could increase the percentage of children reunited with their guardian at the site from whatever your baseline might be at your organization or institution to 100% in the next 6 months. And then finally, for staff, we could look at increasing the number of trained staff members involved in the reunification process by 25% through new and existing resources over the next 6 months. So all of these are just examples, hopefully, to get your wheels turning a little bit and get the ball rolling with things you might want to bring back to your teams and how you could create an aim statement for an initiative that you'd like to take on. And with that, I will turn it over to Christy.
Here, can you guys hear me?
Yes. Yes, we
Good
can.
afternoon. Okay, so we're going to do a quick word cloud activity. What does the word when you talk about activation of a reunification plan, when you have to activate your incident command, what does the word activation mean to you? Just throw your words in there of what your thoughts are when you hear the word activation. staff, resources, need something. Bye. Action. Yes, action. That's what I was looking for. So to activate, you have to take action and call your team together. Identify who your leader is and activate and start that plan. Communication, yes. All right. Anything else? Any other thoughts on what activation means? Required. Okay. Next slide. Okay, so now that we've talked and we've started brainstorming on what activation means, we're going to have a presentation from Carrie Cox. And there we go, trying to pull up my bio. Carrie Cox, she's with Texas Children's Hospital. She has a master's in public policy and administration and emergency management experience at the local, regional, and healthcare sectors. Carrie brings with her a depth understanding of disaster response. Currently serving as a training and exercise program manager at Texas Children's Hospital, Carrie designs and implements training programs to enhance healthcare readiness for emergencies, specializing in family reunification, decontamination response, and crisis communication. Carrie, welcome and thanks for joining us today. Texas Children's has recently had a couple activations, so she's going to share some of those experiences with us today. Thanks.
Thank you, Christy, and thank you guys for having me. So first 60 minutes, of course, in any emergency, we know it's very chaotic, it's hectic, there's a lot of confusion and uncertainty. And so in our training of our teams, our patient and family services teams, we really wanted to zoom in on those first 60 minutes and make sure that is not flawless. We know it'll never be flawless, but we really wanted to streamline it and say, okay, where can we cut out the extra work? Where can we cut out that uncertainty and just make things clear and concise for everyone involved? So the first thing we did is we kind of changed the way people were thinking. We said, okay, we have this max time, and it is impacting the EC first, the emergency center first. But that's not just their problem, that's our problem. That's a whole hospital issue. And so we all need to respond to that. And the way our patient and family services team responds to that looks different than the EC, but it's just as important, and it's going to put just as much of, there's going to be just as much of an emphasis on what they're doing on that side of the house as there is in the immediate medical attention, the medical needs there. Can we see the next slide? Thank you. So when we mobilize 3 groups, social work, child life, and spiritual care. And I apologize about those paragraphs underneath there. Something didn't save right whenever I sent it. So sorry about that, Christy. But just focusing on social work, child life, and spiritual care resources. How did we get them involved in this? We did tons of tabletops. We rehearsed this with them. And we sat them down and said, okay, do you know, are we clear on what your role is in this? Do you see how you're adding value to this? And we really emphasized that, we said, we know the importance of what they're doing in the family reunification aspect, but we really wanted them to see that this is just an extension of your everyday job, and it's just as valuable in an emergency. So we can go to the next slide. So part of talking to them and doing these tabletops with these teams was, okay, we want to evaluate, can we actually get fully activated? Can we ramp up operations within 60 minutes? So we did it kind of workshop style. We poked holes in the plans we had. We questioned things and got creative with our solutions. And we kept coming back to the go boxes. So we did it. We went with it. Our child life team has a go box. Our social work team has a go box. Security even has a go box, and our spiritual care team has a go box as well. We ask them to just put in all those things you know that you're going to need. It's not going to be a question that we're going to need pens and tape and scissors. It's not a question that we're going to need some sort of identification for ourselves. Job action sheets. Again, we're trying to eliminate some of that confusion. So those job action sheets really came in handy. Floor plans. One of the biggest things we see in a lot of emergencies or just event planning is nobody knows what the layout is supposed to be. So we just printed it out. We drew up the room, mocked it up on a computer program, put in every single chair, every single computer workstation, mobile workstation, where families would be having interviews, where the sibling area might be, where they're going to enter, where they'll exit. We went through all those little details because we want to eliminate that mental load in those moments. So we can go to the next slide. All right. And then I want to look at security's role in this also. Clarity is so important. Signage, clear direction in the facility is absolutely imperative. I know Texas Children's is a massive hospital. Just in this one campus here in the heart of Houston, we have 5 buildings and they're all connected by a sky bridge. So that can be very daunting to look at. And when you're looking for your child in the middle of an emergency, the stress I can't imagine. So we want to make signage available in all of those main entry points. Have security or runners, greeters circulating the area, constantly checking in with family members. You should be able to identify them. We kind of teach them what they're looking for. Frantic, maybe they have certain gear on. If it was a sporting event, maybe they have similar sporting event gear. Different things like that, looking for those signs. And then engaging with those families immediately. Having an understanding of the process from child life, social workers, spiritual care providers, security, having a full understanding of that process from start to finish, we found is also super important in making those families feel a sense of comfort and security at our hospital. They should be able to walk up to any person who is working the Family Reunification Center, ask them, where am I in this process? When am I going to see my child? And that person should be able to answer. So that kind of goes back to those job action sheets, understanding what everyone's role is, understanding the plan and really having it memorized. And then I didn't write this down, but included in our plan is a flow sheet. And it's pretty complex flow sheet. I have to give kudos to Chelsea for making this. But it shows the family's flow. So if mom, dad, guardian walks into the hospital, every point and every action that they're going to need to take. And then what's happening behind the scenes as the family is moving through the process. And I believe that is included in the plan that was shared. But those things, those quick, easy fixes, training, go boxes, and then really studying that plan, we found are invaluable in getting us activated within 60 minutes. And I don't have anything else. I think I'm going to pass it back to Christy.
On. So now we're going to break into our small groups, and we're going to have a couple discussions about what we just talked about. So as we break, and the facilitators will lead you through these. Yes, there's a lot of questions. So if you talk fast, you'll get through all of them. If you had in-depth conversations, it's okay if you just get through the first 1 or 2 of them. So do you have any reflections that you would like to share with the group? Any additional takeaways or revelations? Have you thought of a specific area of reunification and tracking that you would like to focus your efforts on during this collaboration? And of course, what are some of your potential barriers and what are your solutions? When they were just talking about the signs and everything else. I'm in a hospital that has had many additions put onto it, and people get lost every single day. So I know how important it's going to be for my facility to make sure they have signage up when we have these special circumstances and when we do activate reunification. So Texas Women in Homeland Security advocating for the advancement of women in the fields of Homeland Security and emergency management. Like to welcome her now. And then after that, we're going to hear from Nita Gupta, who works closely with Sarita and Anna on reunification. And she recently joined Minnesota Children's Hospital from Region 5. Chelsea, it's all yours.
Awesome. I appreciate it. So I'm going to be talking about the less exciting part of this, but one of the most important, and it's communication and what is available for us, what we can and can't speak, and what we or talk about when it comes to disasters, and a few resources as far as for schools and other identified partners. So hospitals are a critical role in responding to pediatric mass casualty incidents, anything requiring reunification, and it's very important to have strong relationships and partnerships, collaborating entities for an effective response. So when a large-scale exercise or emergency impacts children, the response requires specialized, coordinated efforts, not just from hospitals, but from EMS, emergency management agencies, law enforcement, schools, and child welfare services. But unlike adults, we've seen with MCIs, pediatric incidents bring very unique challenges, including specialized medical needs, heightened emotions, emotional trauma, and then complex process for the family reunification itself is also can be a problem. Hospitals must be prepared to activate emergency operations rapidly and assess treating patients, work seamlessly with our external partners, and manage surge capacity. We provide support and reunite children with their families. Right now, what we are looking at is going to be the FERPA. This is the Family Education Rights and Privacy Act. And I wanted to bring to our attention that when we are dealing with our biggest risk as a pediatric hospital, majority of our incidents that involve a surge is going to be involving ISDs or schools. Many of the ones that we've responded to in the past year have been that way. And we've had 8 bus accidents that required a MCI response just since January, 2 of which I will be kind of talking about throughout this presentation. But it's important to understand the information that is available, but also understand how you can use it. So with identifying that there is a life safety or health hazard, you are actually able to receive information from the ISD that you typically would not be receiving on a blue sky day. So this could be anywhere from who's the legal guardian, who is eligible to be released to, as well as medical information and identifying if there's a custody battle currently going on with that child. So a lot of really good information that we can find with your ISDs. So it's really important for us to go ahead and partner with them. So next slide, please. Perfect. Okay. So healthcare emergency managers, our primary role is to ensure that we are always prepared for any incident. Preparation doesn't begin when the crisis hits, and you want to make sure that you are prepared prior to. It starts right now. This is what we call our blue sky days. If you heard me say that term just a moment ago, when things are calm and predictable, because when disasters hit, that's when things become unpredictable. On these days, it's crucial that we focus on building the strong communication, solid partnerships, and the foundation which is going to support you during your actual emergency situation. By developing and nurturing these relationships during this blue sky times, you can lean on these partners during the disaster itself. We also need to prepare communication protocols with internal Partners, when disasters strike, clarity and speed are key. Having pre-established messaging channels, designated spokesperson, and I found this to be the most important is the spokesperson, especially when you're talking with your other school partners and outside stakeholders. And protocols for reaching families. We have one-pagers that we use for our facility that describes a process that they're going to be going through while they're on our campus and the things that they should expect to come up here shortly. You want to know the who's, the what's, the when's, the where's, and the why's. So know who's on your activation, who can activate, because you may hear that there's a mass casualty incident, but you may not have the authority to activate for that incident. So make sure you have the right people at the table that can be doing those moving parts. Next slide. All right. So previous slide, we talked about, it's going to be more your blue sky days. This is what we normally see for like our HIPAA concerns. But HIPAA for Privacy Act and disasters, when we're dealing with a disaster itself, there are many different loopholes that we can utilize during a disaster to share information. You'll see Pulsera here. This is just the tool that we use here at Texas Children's for pre-hospital notification. And I will say this has helped with our family reunification process significantly. So this provides pictures of the ISD phone numbers of what's happening, and it starts the reunification process before the patient even leaves the scene. So this helps us with coordination and facilitation, and then we already have half the information that we can go ahead and start moving our personnel and getting people ready to be reunified. Everyone involved with the reunification process must be aligned. Moving forward, we have experienced in the past that most of our miscommunication comes from outside source. So when you're identifying the mass casualty incident has occurred, then we are told basically there's 100 people coming to your campus, and you're like, I am sure you're not sending me 100 people. So until the fog of war has ended, and we still get information that 22 people are coming, and we actually get 12. In our recent mass casualty incident that we had responded, we had 9 patients on the first one and 12 on the second one, with fatalities on scene on the first one, unfortunately. Our triage details, as well as our mass casualty incident, biggest part of this was that having pre-notification early and activating early and sharing that information, all details can be shared through this Pulsera with our team partners so that we can better identify, better get these children back to their guardians and move forward with the mass casualty incident. Having that prior notification, we allow for mass casualty incident activation at our first facility based on the activation in Pulsera. So from the scene, but before they even notify the hospitals that patients are being transported to your facility, as soon as they have designated your facility as receiving, you'll be notified and receive pictures and identification information immediately. We did not have early notification on the 12 children mass casualty incident that we received. I will tell you that the parent chaperones on site was very helpful. Bringing the school partners into your family reunification center is very necessary, especially if they know these children. It makes it much easier to identify who can be released to who. But in this case, we did not have prior notification. The activation for family reunification was delayed until the patients started arriving. But with the parent chaperones, it did help with moving patients. There was questions like, can you even talk to these parents? Yes, you can, because these parent chaperones are acting as an extension of that ISD, and you can relay information back and forth to them to identify your family reunification process. So I do want to pass this over to Dr. Gupta, because I know she has a lot of information that she's going to be sharing as well that have a little overflow of what I was talking about. So I'm going to pass it over to Dr. Gupta. Thank you, guys.
Hi, thank you so much, Chelsea. Hello, everyone. My name is Neetha Gupta. I'm a pediatric emergency medicine physician at Children's Minnesota and a team leader for Region 5 for Kids Reunification Work Group. I'm going to move on forward. We talked a little bit about HIPAA and what we're allowed to say and what we're not allowed to say. So I'm going to talk about pre-scripted messaging. Next slide, please. So for automated website messaging and things as such, we in a disaster, you can relay information to parents and family, especially if it has been declared a disaster. In the Las Vegas shooting in 2018, there was a great after action report that said for future planning, you should use social media to your advantage, especially when you have no new updates, but families weren't aware if there were any updates. And so what they recommended having is a pre-scripted message to provide to the public at previously set intervals so that families feel well informed. This will help decrease the total amount of calls coming to your facility and decrease frustration, as well as improve your information sharing. Here's a sample script that you could display on your website banner. You could have automatically, if someone calls into your phone, they could read this. In addition, you can provide a link to the family registration form that allows families to remotely provide patient information for a more efficient reunification process. This is helpful if families are not able to physically get to the hospital in time due to the nature of the disaster, or if family members themselves are injured and cannot physically make it to the hospital. Next slide, please. Additionally, in today's age, with social media and heavy cell phone usage, it's likely you're going to have a child who already has a cell phone with them that are in your hospital. They're likely in the pediatric safe area or in the ER, and they're trying to contact their parent. Use this to your advantage. Have a pre-scripted message within your reunification plan that the child can send to their loved ones to help facilitate reunification. This is a sample that you can put and print it out as a signage in your pediatric safe area, and children can just take a picture and send it via text messaging to their parents to help them come to the facility. Next slide, please. This is a study that was published in Disaster Medicine and Public Health Preparedness in 2019 that I just wanted to bring up. It showed what information parents are willing to share in a reunification situation. They were most likely to share birthmarks, piercings, tattoos, hair descriptions, eye skin color, race and gender, language and name, all above about 85% willingness. They were least willing to share DNA or video of their child at less than 75%. Even more interesting, if you look over on the right, 86% trusted a hospital with any personal information about their child, even though they knew this was specifically for reunification, and even less so for every organization that was outside of the hospital. So keep that in mind. Next slide, please. This is a figure from the same study. It shows parents' belief about information sharing. Interesting to note is non-Caucasian parents had statistically significant concerns regarding information sharing compared to Caucasian. Non-Caucasian were more likely to be concerned their child's information would be unprotected. Someone else would use the information to claim the child. Someone would use the information for purposes unrelated to reunification. The information would stay in the database indefinitely, and the information would be shared with Child Protective Services. This highlights ongoing concerns with parent perception of the reunification process, especially when gathering information about their child that could be improved for efficient reunification. So as the reunification planners, we should be mindful about what information we are asking and how we are asking this. Next slide, please. That's all I have for you right now. This is my information if you'd like to reach out to myself or Region 5 for Kids.
I think we're going to hand off to Christy for the debrief of the large section. We're going to actually pull an audible and not do a second breakout session and have just a large group discussion since we don't have as many participants this time around.
Okay. So we just heard about a lot of information and everything else, and there was a question in the chat that did get answered. When it comes to reunification and communication with the community and within your hospital, what are people thinking about? What are your barriers? What are you concerned about? That was a very interesting study that Dr. Gupta just presented on who trusts what happens with their information and who doesn't. Any questions, comments? Just come off mute, put them in the chat. Please don't tell me it's April Fool's Day and you all are just pretending not to answer these questions and aren't there. So
Carrie, yeah, would you please talk a little bit about more Pulsera? Is it all, and this is just going on Kate's question. So Kate, if you want to come off mute, is it does all EMS throughout Texas use this? It's a statewide platform. Other people may have other platforms, like we use Web EOC, and so just wanted to hear what people are using and how
Yes.
it's used.
So the state of Texas contracted with Pulsera to use for all EMS transports. That is Blue Sky Days and Gray Sky Days. So any and all patient transports, whether it's a mass casualty or just a regular slip and fall, goes into Pulsera. Hospitals can kind of buy their own contract with Pulsera as well. They're a private company. And use Pulsera software to kind of track code teams and internal responses. But yeah, that's what Pulsera is. All of our EMS agencies use it to track the scene to the facility.
Missouri just,
Oh, I'm sorry, just with that hospital-wide Pulsera that you have, is that then interconnected with the EMS, so you don't need to have two systems? In Delaware, we have it's called D-Track, and it tracks EMS input patients in there, and you can see all the different hospitals. It's just not as user-friendly as Pulsera sounds like it could be. And I feel like we may have talked about Pulsera at some of the state level stuff.
Yeah, from what I hear, Pulsera is really nice. I will say Texas Children's does not have Pulsera internally. Some of our neighbor hospitals in the medical center do have it. Memorial Hermann has it. And from what I hear, they love it. I believe it does pretty seamlessly transition from EMS to the hospital. So in the training that we've received for Pulsera, it seems like, and Chelsea, correct me if I'm wrong, that if EMS creates a patient on the scene, they will send their arrival time to the hospital. Once the patient arrives at the hospital, if they have this software, can kind of essentially take that patient file and carry it all the way through that patient's stay to discharge. So they have it from the moment they're picked up to the day that they're discharged and released. It seems quite user-friendly from the demonstrations I've seen, but I can't speak to it from a Texas Children's perspective because we don't have it.
Does anyone's system like that also communicate with their EMR to where the patients are directly inputted there, or at least the information from EMS could be inputted? Because that would be.
Now that's been made clear. That was part of the tendency for transfer. Someone sitting with them. And then
in Florida, Pulsera just came. The state just purchased it, so we're in the process of implementing that here at Johns Hopkins All Children's. I've asked that question specifically about them, and we use Epic, as a lot of people do. It doesn't seamlessly integrate into that, but they said that you can basically download files from that patient and upload them into Epic, but it doesn't do it automatically, and there's really no plans to get that to happen anytime soon, but it is something that's on the radar. But we plan on using this internally for reunification, because we're not really sure if the first response is going to implement Pulsera.
I was going to say, Missouri has just gone into a contract with Pulsera for the same thing. So hopefully we'll have more information as the year continues. So we'll have to regroup back on this. There's a question in the chat. Do we think that immigration deportation concerns affect the gathering of information for reunification? And are there any legal ramifications from this?
So this one's a little hard to answer. But I will say that it's in Texas Children's, and from my knowledge, it's patient first, patient centric. What's best for the patient. So taking that information and saying that we would do the family reunification, we would still contact the families. I will tell you that there have been issues with families coming and picking them up and releasing them until you tell them that they're okay and safe to come get their kid. But yes, that is where we're seeing the delay, is the hesitation of undocumented people coming in and trying to pick up their children.
Lindsay, if you'd like to come off mute just to share a little bit of your thoughts. I think this is a great question, and this is something we may want to ask our legal team at PPN just to kind of get a official answer. I mean, I think it's going to depend statewide, but I do think there is going to be wariness, as you said, of like coming to pick up your child or actually identifying your child. But Lindsay, I don't know if you had additional thoughts.
Can you hear me?
Yes.
Yes. I mean, I just think that it's just one more barrier as far as patient trust within our hospital system. So, and not knowing exactly, and I don't think the public always knows like what the legal expectations are. And I know everything varies from state to state. But if you do have somebody who is concerned, you know, like how much information do they give, and as far as how much we can release in certain situations, it's just that it's a hot topic, and it weighs on my mind a lot, and also continuing to build trust with our patients and knowing that we're going to be doing the best for them, so that they don't have to think about other things. They're thinking about themselves or their children and their health.
We have talked about this just in the grand scheme of immigration concerns, and you know, in talking with our risk, if someone was to come to our hospital, is undocumented, and ICE were to come, we were instructed that they need to have a warrant before we would discuss with them or talk with them, and they would not be able to get to our patients without a warrant. And I think that may offer some peace of mind, but I do fear in every situation of our patients' care that this is an issue of them trusting us or even coming if they're sick.
And I think it's difficult when the person who might be undocumented is not the actual patient. You know, so the child is the patient. So the child has the rights with the hospital. But what does the parent have if they're not technically a patient? What rights do they have? So that's just kind of that gray area.
Yeah, I think we have a similar policy where they've stated that if ICE is to come to our hospital, we're supposed to direct them to security, and so that they would the security would handle the protocol and go from there. But it's still very vague because I think there's just so many different things that are changing every day. Chelsea, you've had some great comments in the chat.
No, I just wanted to add, because this is just a little snippet of what we have provided for our social work team about things to think of. Deportation is going to complicate getting medical consent and contacting the caregivers. We have also reached out to the ISD, because most of the things we are seeing is ISD related or the school related incidents. The school reaching out to the families and notifying the families of which hospital to go to pick up their children. That has helped with some of the communication and sharing of. But I will tell you that undocumented parents are probably the biggest concern with reunification because of their concern of coming into the hospital.
I will add to that though, because we're in Texas, we have a high population of undocumented neighbors. And so I think it's written into a lot of our policies that we already have in place. They're not mass casualty policies, but we do have children with undocumented parents who come in all the time. So I think it's worth reaching back out to your teams, probably social work, and just asking them, what is your typical protocol? What do you do with a child when you suspect or you know that their parents are not documented? How do you reunite them? And then trying to stick as closely to that plan as possible. And again, of course, consult your legal teams. But I think the expertise is probably there. It's just a matter of finding it.
All right. That was a great discussion on that. Did any of the facilitators from the first breakout group want to talk about activation or anything that their groups talked about? I'll start it off with one thing that we talked about in trying to identify or get people more engaged, the different groups and everything else, was to make sure when you're talking with those different groups of people in your hospitals, whether it's a social work group, the child life group, your EM physicians, et cetera, to get them more engaged and involved in the reunification process. Always check with them on what their capacity is. What is their normal daily capacity versus when would it become a mass casualty or a mass incident for them? Depending upon the time of day, that might vary or whatever, but just kind of all coming together on when do you really activate reunification and when do you activate a mass casualty incident? What do those numbers look like and what do your resources support at any given time on any given day? So that was one thing that we discussed in our group. Anybody else want to share?
From group 3, we talked a lot about lots of transitions. So transition in personnel and actually transition in like just kind of needing to recreate plans that haven't been dusted off for many, many years, or actually create new plans because it hasn't really been considered. I think a bunch of barriers included staffing and space. And so I think those would be some of the things for us to focus our attention on. I am curious, how many of you have accessed our Padlet? Can you just use the raise your hand? Just trying to get a feel for that. I see one hand.
I'm sorry, what was the question?
The Padlet that we that has the some of the resources. Awesome. So we have a few hands. Great. Oh, it's blocked by your IT. Sorry, Michael. All right. We'll send the links again in follow up. But I think we've placed some of the links in the chat, and so definitely want to be able to have all of those resources in a single place just for you guys. But okay. Sorry,
And I
did
just
not
wanted to share a really good question that came up in our group with everyone. So
Yeah.
when we were talking about, what kind of focus might your team want to take within this reunification domain and the aim statement examples, the question was thinking we had to kind of do all of this. Like, isn't the overall goal, creating this reunification plan and optimizing that within the facilities? So we had a good conversation that really is our overall goal and our global aim to optimize reunification, but we know that everybody's on a different phase on that journey. So like you said, Anna, some might have a plan that hasn't been used in a long time and we want to dust it off, or some might not have a plan. So we're going to start, a lot earlier in that phase. So thinking of the time in the collaborative as, we're going to want you to take one kind of piece or one bite out of this bigger thing that you're going to be tackling within your organization. And if you want to have that scope narrowed in, a little bit more to that one area, it gives you something that you can track and kind of measure and monitor throughout your progress in the collaborative. And then that's, one step kind of towards this overall goal. So just wanted to kind of put that out there if folks didn't maybe have that kind of bird's eye view yet.
And I'm just going to share one resource that we have on our Padlet. And if you guys can't access it, just send us an email and we're happy to actually send out the individual resource links. But if you can see, this is a just kind of I would call it a gap analysis or a progress report that you can choose to use or not use. It's based on the EIIC disaster checklist. And so you can actually just say, oh, do I have an existing plan? And then does the plan address these 4 areas within the domain 6 of the EIIC disaster checklist? And then from this, it'll hopefully help you narrow down, or if there's some portion of this that's really resonating with you, then you can choose to work on it, and hopefully you'll progress from one to having a process, for example, to track unaccompanied children who present to the ED, to like going from not having a process to having a process. Does that make sense? So this is here, and it was designed for our participants in mind. And then hopefully giving you some more educational resources to help.
Katie, I think you had your hand up. I want to make sure if there was any question that you wanted to ask.
No, I just realized that. Sorry, I hadn't put it down.
Okay, thanks.
Sorry about that.
Well, thank you. I thank everybody again. I know, as we said, you're very busy, and we really do want to make this process meaningful for you. And so please email Christy. I don't know if you want to have your email, or actually Laura, the PPN email. If there's anything that you think we should be covering, actually we should do this poll. You know, as far as, let's do the other question, or
sorry, we were hoping to understand if facilitated discussions, like what your ideal length would be for that. And so you have anywhere between 10 and 30 minutes here. And it looks like we're getting some responses, but I'm also going to move forward with the next poll, which is basically a ranking poll. And this one, just kind of, if you guys want to be in the same one every single time, can you let us know? Or if you like being randomly randomly put together. And then if you were to be in the same, I think we can skip this one actually. Okay. We're going to be hosting a lot of different Padlets for each session that will actually give you additional resources to learn about those specific areas with respect to the session topic line. And so definitely we want, hopefully you'll be able to access that. If there's a problem, we'll also try and put individual links onto the focus area website. And then we do actually have a Padlet for those of you who participated in virtual tabletops or are actually running tabletops at your own institution, and we'll have a showcase in July. And then I think this is our last poll. We're actually going to be covering leadership and organization for reunification in June. And we would like to know ahead of time if you have any questions that you would like us to address. And I will leave this poll open for a while. So like, even if you've thought about it afterwards, if you have specific questions that you would like to relay to us, we would love to address those in our future session. Laura, I'm going to turn it over to you for DRC updates.
Sure. So the focus area web pages are live. I put the link to the reunification page in the chat right before the email. You can use the DNC PPN email, or you can email me or Julie Shelton directly if you have any questions or comments. The virtual tabletop exercises that are hosted by DRC and PPN are moving along. March, April, May, and June. There's a training for facilitators and evaluators. If those folks that are identified cannot attend, they can view a recording. It's not too late to sign up to attend a VTTX. So please consider that if you want to. There's more than adequate space. So if you attended a BTTX, you will receive a very brief survey on how things went. And then in about a month, we're going to send you one related to an after action so we can capture what you learned during those sessions, whether it was your own facility-led TTX or the virtual ones hosted by DRC. Next slide, please. More information about the BTTXs. This was shared earlier in a checklist. It's basically the step-by-step process. There are questions about communication, so every facilitator and evaluator for the teams that signed up, and those folks were identified, has received communications about their particular event. If you're a team leader or a team member and you don't know the details, you need to reach out to the facilitator and or the evaluator or have a group discussion so that you're in the loop. And if you don't have enough information, you can email us or Chris McCarthy. I can help put you in touch with him if you have any questions at all. Next slide, please. I'm pretty sure you've heard about the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals, also known as PDPAC. It is launching. It's very, very important that every children's hospital complete this assessment. The process happens in 2 steps. Registration will be open tomorrow. I actually think it's open today. Before you register your institution, you need to know who your emergency manager or the point of contact is going to be that's going to review the entire survey. And this survey serves as your environmental scan for this quality improvement collaborative. And the reason why that is so important is that there are about 12 different domains or sections for this survey. And you, as the point of contact, can say, well, I'm not really the SME for children and youth with special healthcare needs or for another topic area, but I'm going to delegate those 10 questions to this one person. So before you register, take a look at the topics, and you can do that by scrolling up when you go to the registration link, and you can see the topics, and then you can be prepared with the name and the email of the person that you want to identify as the point of contact to receive that. And then you, as the submitter, get to see their responses, or if they haven't responded, you can prompt them or fill out those. You should have at least a month. The sooner you register, the sooner your organization will get this survey. It may take a while to complete it. It is lengthy, but it is the first inaugural scan of how children's hospitals are doing in terms of preparing for disaster response, pediatric-wise. Next slide, please. Sorry, my kitten is getting in the way. You can skip that slide. The next session is the collaborative session, so that you'll hear more about the PDPAC for those that haven't yet finished it. And then each of these focus areas will provide information on what they've learned as most important top highlight areas that are either things that you're sharing with the whole group or questions that still require answers. And then the June and July sessions, we will go back to meeting by focus area. So please note the time. For the collaborative session, it's at 1 Central. And excuse the typo, the focus area session for reunification starts at 2 Central Time and goes till 3:45. And just know that there's other sessions before that. So there's very little time between the 2 sessions. Some of you go to both and you understand that. And I did want to thank all of our speakers and our oversight group people again, as well as all of you for hanging with us here. Next slide. Zazvam. There is your code. I'm going to copy it into the chat if you want to claim CE. And we have a very nice staff person that helps you if there's any glitch there. Next slide. Feel free to move by. That seems like a duplicate. Okay, the session evaluation. Just 1 second. Hopefully you can see it and begin responding.
And we just want to thank you again. We will stay on if you have any additional questions or feedback. But after you finish your evaluation and get your credit for your CEs, we wish you the best of weeks and weekend. Or I'm already thinking about the weekend and it's only Tuesday. So thank you again, but we will stay on. Thank you.